Hey guys, it's Jay and I'm back again tonight with another video. Listen, before anything else, all of you who have subscribed to my channel, I thank you. And those of you who gave the thumbs up and those of you who have not decided, we ask that you will stay with us because we have an enormous amount of information to give you according to the therapy multiple choice exam. Now, we like to talk about a very important subject that every respiratory therapy should always have in their mind when they put someone on the ventilator. So tonight we want to talk about mechanical ventilation liberation. It should always be your goal to take someone off a ventilator after you have placed them on one. Are you ready to go? Let's go. Okay guys, tonight again is a very important subject and we are going to turn this thing up a little bit every week now. We're going to go higher and more depth on more important issues, but we're giving you bite-sized information so that you can retain it and use it for the exam. Now, when we place someone on mechanical ventilation as respiratory therapists, our number one goal is to get them off as soon as possible. Before the patient can be liberated, they must meet the criteria. And I want you to get used to hearing and seeing the word liberated because we're getting away from the term weaning. But they must meet criteria. What are those criteria? Well, all of the vital signs must be within normal range. Arterial blood gases must be good. The CO2 do not have to be in range, and I ain't range 35 to 45 for chronic lungers or patients that are COPD. If the pH is fully compensated. They may have a funky CO2, but the pH is within a normal range which compensate for the CO2. So be careful right there because COPD will not have a CO2 within a normal range of 35 and 45, but yet they just fine. And liberating the patient, a spontaneous tidal volume must be at least 5 milliliters a kilogram. Vital capacity must be at least 10 milliliters a kilogram. The MIP, maximum intravenous pressure, has to be greater than minus 20 centimeters of water. And on this exam, if you don't see minus 20 and just 20, it's the same thing. Don't worry about the minus side. QSQT, the shunt equation, must be at least 20% or less. Dead space tidal volume ratio must be 60% or less. And Roman number 2, the AA gradient has to be less than 300. Always remember that when we are liberating the patient, we can always use pressure support to help augment that ET2. It's not uncommon for you to see or for the exam to ask you about pressure support when you're liberating someone from the mechanical ventilator. The RSBI should be less than 106. Some books say 105, same thing. And the way that you get this is by dividing respiratory rate and tidal volume. This is your shallow breathing index. And the way that you get that, respiratory rate divided by tidal volume. Next is a very important and very crucial statement. Underlying problem must be resolved. Whatever placed that patient on the mechanical ventilator must be resolved before we can liberate them. And then they may have an infection or pulmonary embolism, but those things have to be resolved before we can liberate them. Remember again, chronic underlying problem like COPD do not need to be fully reversed because we can't reverse the damage that is already done to the lung, but we can still get them off of the ventilator. Now, newsflash, if any of these criteria are not met, liberation should be terminated. You can try again the next day, leave them alone for the rest of the day, but do not force it. If they do not meet the criteria, do not force them. And Roman number 3, always check exhale volume. Now, in order for you to check an exhale volume, you will need a volume measuring device such as a vein respirometer. Make sure you remember that. Check your minute ventilation. And we get minute ventilation by doing what? Respiratory rate times tidal volume. Exactly. Is how you get your minute ventilation. Please check compliance of the patient lung. Dynamic compliance relates to airway resistance. And what do? We suction the patient or give the patient bronchodilator if they're wheezing. Static compliance Static compliance relates to the stiffness of the patient lung. And we always treat these patients with PEEP. Now, another thing about static compliance is that if your static compliance is over 50 centimeters of water, then we need to consider changing the mode. And if you have to change mechanical ventilation due to stiff lung, you have a couple of choices that I favor. You should, first of all, place them on pressure control. Usually works every time. But if that doesn't work, you can always use high frequency ventilation, okay? And at high frequency, they get a little small breath that really doesn't hurt the patient. And there you have it. Remember, for this exam, you will place someone on the ventilator, but there will be questions on this exam that will test your knowledge as to how and what to look for to get them off of the ventilator. Mainly on the exam, you will see questions pertaining to COPDs. And make sure you are on top of your game. You cannot change a patient lung damage, okay? But look at those ABGs and make sure that that pH is compensated, which means that the patient is ventilating just fine. Newsflash again, if any of these criteria are not met, liberation should be terminated. And there you have it. Okay, guys, mechanical ventilation liberation is very important to the exam.